So you had an interesting case presentation on anomalous right coronary artery. Sir, how common is this disease and how do we establish diagnosis of such an entity?
There have been many studies, Rishi, that have been done on anomalous coronary arteries as well as different abnormalities. And in the general population, it is felt that the incidence of abnormalities of the coronary artery are approximately 1%. However, in patients who have congenital heart disease, this could extend up to 3 to 6% of the population. Now, most of these anomalies could be quite benign. For example, circumflex artery arising from the right sinus, a single coronary artery, these could be benign abnormalities. But there are two situations or maybe three situations where they could be potentially quite dangerous. One is the left coronary artery arising from the pulmonary artery. Now, this means you are getting deoxygenated blood. This patient certainly is having an ongoing ischemia, will be established right up in front as a child, and this child or this patient may actually need to have a surgery or will need to have a surgery done whereby the coronary implantation has to be put back into the aorta, create a new ostium.
Right.
But this was not my patient. My patient was the anomalous right coronary artery arising, a 38-year-old asymptomatic, found out on a CT coronary angiography. But this asymptomatic is the large number of these patients, but a few of them, maybe 20% of them, will have some symptoms or the other. For example, they may have angina, they could have syncope, they could have breathlessness or heart failure. So in a young individual below the age of 35, if you have any of these four symptoms that we presented it, you must, besides other conditions like blockages in the coronary arteries, you must think of the anomalous coronary artery. There could be other reasons like hypertrophic cardiomyopathy also, but this is one of the situations. Now, in my patient, since he was asymptomatic, we have to establish whether he runs a malignant course or not.
True.
Now, most of these right coronary arteries arising are not malignant, but about 20% could be. Now, when they are malignant, what we mean is that they could have a sudden cardiac event, which could be a sudden cardiac death or a sudden myocardial infarction. Now, that's what you want to prevent. So, for that, besides the imaging study like a CT, you have to then go and try to establish whether ischemia is there or not. That you could do either by a dobutamine echo test, dobutamine echo stress test, or by a nuclear scan, or by a cardiac MR, stress cardiac MR. If you demonstrate ischemia in this kind of a patient, then you have to discuss with the patient and the relatives whether he would like to have a surgery done whereby the coronary can be reimplanted in the proper sinus, or whether he could even have a PCI with IVS guided stenting to prevent the artery from being compressed. But the first important thing that you must tell this patient is that he should not compete in any competitive sports.
Okay.
Because when you go into competitive sports, there is a dilatation of both the aorta and the pulmonary artery, and this may cause a squeezing of the coronary artery as it traverses between the aorta and the pulmonary artery for those who have a malignant course. 80% of them, the coronary artery may go across in front of the aorta, or it may go across behind the heart. So in that's not a malignant course.
Correct.
So in that group of patients, you need not do anything. But in this, you have to clearly tell them that they should not compete. And then in this situation, you have to discuss with them whether they would like to go for surgery or whether they would be encouraged to take beta blockers. Because it has been found that if you give them beta blockers, their chances of sudden cardiac death become almost zero.
Okay.
So this is what you can do for this patient. On the other hand, if my patient had a left coronary artery arising from the right sinus, that is even more malignant. And if that happens to be the case, and we show that there is a malignant course of once again traversing between the pulmonary and aorta, those patients generally require surgery or an angioplasty with a stent between that, guided by IVS, so as to prevent a sudden cardiac event. Because in a big group of patients who were studied, autopsy, young patients who died below the age of 35, a good percentage of them had this anomalous left coronary artery arising from the right sinus. So it's not a benign condition for all patients.
So what will be the approach towards that asymptomatic, which is large number, 80%? So do we leave them just observe, or there is something need to be done about
If
this?
they are above the age of 35, 40, and they've had no symptoms, you guide them properly, and you see that possibly put them on beta blocker and find out that they don't have ischemia by doing a stress test or doing then you just follow them up. On the other hand, if you prove ischemia by one of these tests and they have a so-called malignant course and they are younger, you have to discuss with them, especially if they have a left coronary artery, you have to tell them that they would be better off with a surgical procedure because you would not be completing your job. In the case of the right coronary artery coming from the left system and the patient is older than 35, you could discuss with him a medical management. So there's no end to this particular thing. There is no definite guideline. In some cases like the Al-Kappa, where you have the left coronary artery arising from the pulmonary artery, definite surgery. If you have the left coronary coming in from the right sinus and the patient, you prove ischemia, malignant course, certainly surgery. Right coronary artery is still debatable.
And how is their prognosis or overall prognosis of these patients?
The overall prognosis is very good. The asymptomatic patient, no ischemia, over the age of 35, prognosis is very good, except no competitive sport. Okay, because in competitive sport, they may have a sudden cardiac event.
Correct.
But otherwise, their prognosis is very good. If they don't have any malignant course or if they do not have any evidence of ischemia and they are above the age of 35 or 40.
So what will be our message to large number of physicians and cardiologists? When do they suspect that there could be an anomalous coronary tree, and how do they?
One, on the symptoms of young patients. If you have ischemic symptoms in young patients, if you have a syncope in a young patient, if you have heart failure in a young patient below the age of 35 or 40, you must think of this as one of the situations. Second, it is found in asymptomatic patients by routine testing. For example, in this patient, for some reason or the other, underwent a CT coronary angio and you found this, then you must test for ischemia. Third is when you are doing a coronary angiogram for one of these patients for something else. Maybe he had an ischemic thing and he had to, and you found that there was an anomalous coronary artery. So you must go further and establish the course by doing a CT and also establish whether there is ischemia or not. So these are the three ways in which you would kind of come to some diagnosis as far as this is concerned.
True, so I think so. Again, the right degree of suspicion in young patients, especially if they are presenting with chest pain or some other ischemic symptom, they need to be evaluated further.
For this condition
For
also.
this condition
also. It's not the only cause,
Correct.
but it is one of the causes.
It should be excluded.
It should be looked for. It should be excluded before you can say, because these patients, especially those with the left coronary arising from the right sinus and having a malignant course between, are a high potential for a sudden cardiac death.
True. Thank you, sir. Thanks a lot for joining us today.